Welcome to AETCM, the Emergency Medicine Channel. So today we're discussing a young patient who has come to ER with complaints of back pains. 37-year-old male presented to ER with complaints of back pain. On primary survey, patient was conscious oriented. Started with the primary survey, airway was patent, no added sounds. Breathing wise, patient had saturation of 97% at room air and respiratory rate of 22 per minute. Circulation wise, pulse rate was 80 per minute and BP was 130 per 70, sir. And disability GCS was E4, V5, M6, and pupils were bilaterally reactive to light. And exposure patient's temperature was febrile and GRBS was 120 mg per dl. In primary survey, there is no any active interventions. His pain at present, he had already taken treatment from outside hospital, so pain score was only 2/10 as of now. And coming further to the history is like secondary survey, sir. Patient is a known case of a 33-year young patient, known case of systemic hypertension for last 3 years on telmisartan, sir. And he had a traffic injury 1 year ago and he developed back pain at that point of time. And he had taken combiflam, which is an NSAID at that point of time. And he had developed a kidney injury in the past, AKI episode, and he was hospitalized at that time. After that, serum creatinine came to baseline of 0.9, sir. And right now, patient had another traffic injury 10 days ago and he was taken to local hospital, in view of which he was started on Lyserdi, which is another type of NSAID. Post using this NSAID, which contains diclofenac and serratiopeptidase. Right now, patient developed bilateral lower back pains. In the local hospital, baseline tests were done in which serum creatinine was 1.80. For which he was referred for further management. So on arrival, first thing we did was an ABG to check the electrolyte imbalance and because of the rising creat. In VBG, patient had no acid-base disorder, but bicarb was 17, sir. And serum creatinine VBG was 3.40. Potassium was on the higher side of 4.9, sir. So the patient had no history of any reduced urine output, so we hydrated the patient with fluids. Apart from that, ultrasound abdomen was done because he's complaining of lower back pain. There was no any HUN, no any obstructive features, but the corticomedullary differentiation was preserved. Corticomedullary differentiation was preserved with bulky kidneys, showing bulky kidneys. In view of the bulky kidneys, we further proceeded with CT KUB for better imaging. They documented as perinephric fat stranding was present, but there is no perinephric fluid collection or any other features of pyelonephritis. And his counts wise, CRP was 40, sir, and WBC was 11,000 within normal range. But creat was elevated. That was the only issue. As the history suggests, his worsening creatinine started right after the NSAID use, and also in the past such episode was prevalent, so we had considered it to be NSAID induced AKI. And his urea was 1 to creatinine ratio was calculated. It was 10, sir. So like
what is the urea in this patient?
3, urea calculated and kept. Urea was 39.8 on arrival and creat was 3.70, sir.
What is the normal ratio between urea creatinine in acute renal injury?
Acute renal injury.
Intrinsic renal injury.
Intrinsic renal injury less than 20:1.
1:20.
1:20.
In pre-renal.
Greater than 1.
Okay. If urea is very high, then it is due to pre-renal injury.
Because of hypovolemia can be the.
Okay. Here it is due to drug-induced renal
tubular
injury. How do they present to you, these patients? What are the presentation?
Presentation would be like complications of the AKI, majorly like severe metabolic acidosis with hyperkalemia.
Normally, what all findings will be an acute kidney injury due to drug? Any drug, especially NSAIDs.
Vomiting. Like
Vomiting,
symptoms.
there is uremia.
Uremia, because of uremia, the side effects of uremia, gastritis, uremic gastritis.
Gastritis is a feature of NSAID. I am asking about renal injury. What are the
Reduced
different
urine output.
presentations of renal injury due to drug?
Edema, sir. No.
Pedal edema.
Pedal.
Okay. Edema. Then
Reduced urine output.
reduced urine output. Okay,
Then ECG, like
I am only talking about kidney presentation.
Prompting.
Albuminuria. Okay, but that is not very common.
In severe cases, discoloration of urine.
What discoloration?
Rhabdomyolysis can be.
reddish discoloration.
Okay, blood in urine.
Blood in
Hematuria. Hematuria is one common presentation. Pedal edema due to hypoalbuminemia is another presentation. Hypertension is another important feature. Then this patient had renal pain
Yes, sir.
because
Bilateral
of acute
renal.
inflammation. Okay.
And as he's an 33-year-old with known case of hypertension, even evaluated for the same by doing renal artery Doppler.
Okay.
But renal artery was with normal diameter and no stenosis was seen, sir. But family history of parents having hypertension, and his younger brother is also having hypertension at young age itself.
Okay. Did he had any urine eosinophils?
No, we had in view of drug-induced AKI, we had sent for urine eosinophils, but it was negative, sir.
Negative.
Negative.
Okay. Did he required any dialysis?
No, sir.
Nothing. Was
Nothing. He had preserved urine output with preserved metabolic, like a normal acid-based disorder. So on hydration, patient got better.
Okay. So what are the things you should know about drug-induced renal injury? What you read?
Sir, in drug-induced renal injury, especially NSAIDs are actually prostaglandin inhibitor. Okay. So they
here one more drug is there. He's on AC inhibitors.
Yes,
Can
tell
it
me
produce,
certain he
renal
was on.
failure?
Yes, sir, tell me sir.
Can it present with renal?
Precipitate it can
Worsen.
It can worsen it.
Normally it will not worsen. Worsen means all patients we are starting. No, we are starting AC inhibitor for many patients. There are some subset of patients where it can induce renal failure.
Stenosis of renal artery
Renal artery
stenosis.
stenosis is one of the common.
Hypovolemic any.
Already patient is having hypovolemia, it can
worsen.
occur. Okay. Normally this is a renoprotective drug. AC inhibitor is a renoprotective drug. But during initial phase of the drug, we have to monitor the creatinine, whether the creatinine increases or not. Afterwards, it will never increase the creatinine. Okay. But when the creatinine increases due to some other reason, like diabetes or drug here, we have to stop the drug. Okay. Temporarily, we have to withhold the AC inhibitor. Otherwise, it can increase. The problem can increase. Okay.
So regarding intrinsic acute kidney injury to drugs, there are various actions by which drugs causes kidney.
Rifle criteria.
The locations where the specific drugs cause that, like suppose NSAIDs and these actually inhibit the prostaglandins. Because of inhibition of prostaglandins, local vasodilation will be reduced. So the GFR will be affected. That is the reason why the acute kidney injury develops in NSAID-induced kidney injury. And some might be tubular toxic, like aminoglycosides, amphotericin B, and our HIV retroviral
drug. So just continue that. But this drug is single dose is producing all this problem. Single dose.
Yes.
Okay. But aminoglycoside is a cumulative dose. 3-4 days it will take. Okay. So sometimes it can be idiosyncratic reaction. You know what it is. What is it?
Not dose dependent.
It is not dose dependent. Single dose is enough to develop all the complication. Whereas normally aminoglycosides, it takes some time to create problem. Okay, that drug also produce sometimes can produce first dose reaction. Okay, continue.
And some drugs causes rhabdomyolysis and causes AKI, such as cocaine and statins, especially. And some causes intratubular obstruction, like methotrexate and chemotherapeutic agents. And
so how do you treat? You continue, but how do you treat rhabdomyolysis induced renal failure? We have patients here in ICU. How do you treat it?
So we need to target
fluids. Fluids are the treatment of choice. Whereas in other conditions like drug-induced nephrotoxicity, fluids are not the choice. Fluid is not required there. You can give fluids to know whether the patient is having good output or not. But in rhabdomyolysis or hyperkalemia, fluids are the choice of treatment. Okay.
Yes. Next other mechanism is interstitial nephritis, which NSAIDs and cephalosporins and penicillins cause. Other is HUS, hemolytic uremic syndrome, caused by the drug-induced HUS like mitomycin, cocaine, and cyclosporin, like immunomodulators, which they cause. These are the mechanisms by which kidney injury can happen because of the drugs.
Most common drug will be NSAID only, because that we are practicing every day. Then aminoglycosides.
Next, coming to the basic to the ER scenario, in the emergency scenario, whenever we receive the patient, we just get a creatine value by which we cannot decide the like damage criteria, rifle criteria, criterion kit go, because it's a duration. Depending upon the hours, it is defined. Depending on the serum creatinine or the urine output over the 6 hours, 18 hours, that is how we define these lines. So it's not ER, it's in the ICU. Management.
So you need to have a follow-up
of the creatine. And serum creatine will show the absolute creatine value after 12 to 24 hours. So now when we take the creatine, if the kidney injury is still persisting, next value would tell us the damage, how much.
Any other investigations available to know that?
Biomarkers can be used like cystatin C and GAL. These are the new agents which are
GAL
being used.
is available now that can be used for this purpose, to know whether the kidney injury is setting in or not.
Yes, that are the basic things.
Now how do you treat this type of conditions?
Initial management as
like you have a patient with aminoglycoside induced renal toxicity, what do you do?
In that view, first the complications of acute kidney injury would be acidosis and dyselectrolytemia. That should be taken care. If not possible with hydration, if it's not responding to hydration, then the next line would be dialysis.
Dialysis is a secondary issue. We have to dialyze if the patient is having complications. Otherwise, how do you proceed?
Stop. Initially, anything is stop the drug.
Stop the most important is stop the drug. Only thing, aminoglycoside, sometimes if you can reduce the dose, it may get settled after some times. But normally now we have better choices. Aminoglycosides, instead of aminoglycoside, you can go for other drugs. So you can switch to other drugs. Previously we used to reduce the dose and see, because there were no other choices. Now there are multiple choices. You can switch. So stop the drug. Then what are the complications you anticipate in acute renal failure? Complication. Most important is electrolyte imbalance, hyperkalemia. How do you manage hyperkalemia? What was potassium?
In this patient, initial potassium was 4.9, but as we started hydration, it went down to 3.5. Never, we never had to give any hyperkalemic measures.
So there are two problems. One is kidney is completely shut down. There you get all type of electrolyte imbalance, like hyperkalemia can be there. There are some conditions where the kidney is losing everything. Hyponatremia, hypokalemia, everything can be seen in this type of patients. So renal failure doesn't mean that all will have hyperkalemia. But hyperkalemia is the most common problem what we are facing. How do you manage hyperkalemia in acute renal failure? Is there a difference between hyperkalemia in acute renal failure and chronic renal failure?
Yes, sir. In chronic renal failure, because the kidneys, patient would be on dialysis, that
I'm not asking, is there a different clinical difference in hyperkalemia?
In chronic renal failure, patient will be accustomed to higher values of potassium, so
even if it is slightly higher, 5 or 6, no need to worry. You can treat with normal your practice. But in acute renal failure, patient can have severe arrhythmias due to hyperkalemia in acute renal failure. What are the common arrhythmias you see? What are the ECG changes you see?
ECG ventricular.
What are the ECG changes you see in hyperkalemia? Tall T waves. That is last. First
we'll start with tall T waves, then wide QRS, prolonged.
First one is always bradycardia. So most of the patients in renal failure, you can see here, their heart rate will be very low. So that is a first sign. But first ECG finding may be very tall T waves. So you get bradycardia, very tall T waves. Then you get wide QRS complex, wide PR interval, sine wave pattern. Then patient go to ventricular arrhythmias. How do you manage this hyperkalemia other than dialysis?
Other than dialysis, initially the arrhythmia part will be managed by giving calcium gluconate, as it is a cardioprotective drug against hyperkalemia. Apart from that, to reduce the potassium levels in the blood, we have
How
to
do you give calcium gluconate?
10% of 10 ml.
10% 10 ml.
Okay. What is the difference between calcium chloride and
Calcium gluconate.
gluconate?
Calcium chloride will
It is not available in our hospital.
it will be having higher percentage of calcium,
Uh-huh.
and that could be
How many
advantage.
times?
Three,
At least three times
it
higher
is.
than your normal this one. Okay.
Other than that cardioprotective action of calcium gluconate, we need to consider transcellular shift of potassium into the cells. We can do it by giving beta agonists like nebulization with salbutamol.
How many nebulizations you have?
Basically, we are the ideally it would be like each cycle lasting 20 minutes, like
It is in
3
asthma.
cycles.
That is in asthma. Here you require a very high dose, at least 3 times higher dose than this one, what you give routinely. So that's why it is not a good practice. Patient will have tachycardia, patient will have palpitations, so many abnormal problems he can have. Okay. There is not a good drug in clinical practice. You can give normal nebulization, we give every 20 minutes one. Here it is not like that. Continuously you have to give. Okay.
The other would be giving insulin along with dextrose solution. GI
How
bolus.
much insulin? How much?
8 units of insulin is given along with 100 ml of 5%
The
DNS.
patient is already diabetic.
Then directly insulin can, like if the blood sugar is already elevated more
very
than
high.
300, then we can give 8 units directly.
If the patient is having hypoglycemia.
Then only dextrose enough is
So
enough.
both dextrose and insulin will have same action.
Synergy.
Okay. So that you should know. The patient arrests in front of you, what you do? Hyperkalemic arrest. What is the drug of choice?
Soda bicarbonate.
Soda bicarbonate.
Soda
Sodium bicarbonate is the treatment there. Okay. But routine conditions, we don't prefer sodium bicarbonate. We can give, but in arrest, that is a drug of choice. What other problems can occur in acute renal failure other than hyperkalemia?
Uremia.
How do you diagnose uremia? Uremic encephalopathy. What is the
Bleeding.
clinical finding?
Hyperactive. Like, he will be altered, drowsy, agitated.
What is the clinical sign of encephalopathy? What is it? Flapping tremor.
Flapping.
So you look for flapping tremor, that will be there. Okay, then. Other complications of uremia.
Other complications, there can be pericarditis.
Pericarditis and pericardial efficiency. What is the difference between normal viral pericarditis and uremic pericarditis? The difference. What is the difference? One is painful, one is painless. Which is painful?
Uremic pericarditis is painless.
It is painless. Uremic pericarditis and pericardial effusion is painless. Whereas viral, bacterial, all are painful. Okay. What are other features can be there other than all these things?
Gastritis.
Gastritis. Severe abdominal pain can be there. Uremia is one of the cause for abdominal pain. Okay, then. Any other electrolyte or mineral deficiency can be there. Vitamin deficiency can be there. You see a lot of patients here now, renal failure. What all drugs are there in their chart? You should only see that. Hypocalcemia, vitamin D deficiency, hypocalcemia, folic acid deficiency, hemoglobin deficiency. So many things you are seeing. So you should remember all these things. Whenever you see a renal failure patients, we have to correct all these things. Okay. Suppose the patient is having renal failure for 1 month, definitely he'll develop anemia. Okay. So we have to replace folic acid and erythropoietin. Okay. You are treating in your ICU. Should know all these things. Okay, then. Urine findings, anything is there in this urine finding?
No, sir. Urine report, urine routine examination.
Any cast, blood cells,
No,
hemoglobin, RBCs, anything
negative.
is there? Everything is negative. Okay. Now what advice you give to this patient?
Like furtherly, you should avoid taking NSAID and even renal toxic drug, any further medication management.
Avoid NSAIDs, that is most important. Then for pain, what you will take then?
Non-NSAID like opioid or even paracetamol. Paracetamol initially, if it's severe, then opioids can
be given. Is opioid safe in renal failure?
Yes, sir. Opioid is safe.
Okay. Suppose a patient is already having complete renal failure. That means he is on dialysis. Can we give NSAIDs?
No. If he's on dialysis, then NSAID will be flushed through
If he's
dialysis.
having severe pain, can you give NSAID? Is it dangerous? Kidney is already damaged.
It will further damage if you give NSAID.
Kidney is already damaged. He is doing replacement dialysis. Actually, there is no problem. Already damaged kidney, NSAID cannot do further. But we try to avoid because it has got some other properties. This drug has got some other properties. What are the properties of NSAIDs?
Steroid.
Theoretically, there is no problem, but we try to avoid because some other properties are there for this drug that can create problem.
Prostaglandin inhibitor.
What is the property? What is the property you don't want to have in a patient with renal failure? What will happen to water? What will happen to salt?
Water, it will increase the water fluid.
Talk like medical student. Water
Fluid,
retention.
water retention. Water
Sodium retention. These are all the normal mechanism of action of NSAIDs. Okay. So we try to avoid, if complete renal failure, even if we give NSAID, nothing will happen because kidneys are already damaged. But patient can develop hypertension, sodium retention, water retention. So better to avoid this type of drugs. Okay. And morphine, pethidine, all these things, there are no major contraindication because if the patient is already on dialysis, nothing will happen. Okay. But even then, we try to avoid all these drugs because a sedation in this patient can mask the findings of encephalopathy. So try to avoid all these drugs. Paracetamol will be the only safe option in this type of patients for pain. We had given buprenorphine patch for this patient.
Yes. We had given some.
Anything else you want to add? Rifle criteria?
Yes. Rifle criteria is depending upon the creatine.
What is rifle criteria? Can you tell what is that?
Risk.
Failure, loss of function, end-stage kidney disease.
Okay.
We divide this as per the creatine.
Another criteria is KDIGO.
KDIGO.
You should learn all these things. Okay, what is rifle criteria?
Rifle criteria, first risk would be if the baseline's creatine is greater than 1.5.
Okay.
And second, injury would be greater than 2 baseline of GFR, decreasing GFR greater than 2 of the baseline. Failure would be if baseline create greater than 4 mg per dl with an acute rise of 0.5 mg per dl. Okay. And loss will be if renal function has, kidney is not functioning for greater than 4 weeks. Okay. And end stage renal disease more than 6 weeks. It is end stage. Yes.
So this patient is completely recovered and discharged.
Yes, his creat was better.
Okay, thank you.
Yes.